Hi, this will be the continuation of your discussion on the anatomy and physiology of nervous system. So in this specific discussion, we'll be talking about the peripheral nervous system and then the common assessment findings on a patient with neurologic problems. Now, so your peripheral nervous system. The main role of your peripheral nervous system is to link the central nervous system to the rest of the body. It will be the one that will be linking your brain and your spinal cord to the rest of the body. So your central nervous system is composed of the following. You have your cranial nerves, your spinal nerves, and then your autonomic nervous system. Now, recall that you have your 12 cranial nerves. So class, you should be able to memorize already your 12 cranial nerves, how they are assessed, what are their specific functions, and what are the organs that they would be affecting. So class, among the 12 cranial nerves, you have your vagus nerve, the only nerve that would extend to the ventral body cavity. If you can recall your vagus nerve, it is the nerve that would innervate or that would trigger your acid production in the stomach. That's why in our patients with GERD, recall that we have the procedure vagotomy. In the procedure vagotomy, we are trying to sever your vagus nerve in such a way that it will not be able to trigger the production of acid into your stomach. Among the 12 cranial nerves here listed, there are 3 which are considered to be purely sensory. So these nerves that are purely sensory are your olfactory nerve, you have your optic nerve, and then you also have your acoustic nerve. Okay, your olfactory nerve, recall olfactory, that is for your smell. Optic is for your vision. And your acoustic, also known as your vestibulocochlear nerve, is intended for your sense of hearing. Okay, so these are your 12 cranial nerves. If you would want to go over them using this image, you may pause the slide. Now, class, your 12 cranial nerves are enumerated on the slide and then their types are enumerated also. Okay, it is wise for you to use a mnemonic and memorizing these 12 cranial nerves to aid in your mastery. And then class, it is wise for you to memorize the type of these nerves as this would allow you also to master their specific function. Okay, so we have here the mnemonic OOO, to touch and feel a green vegetable, heaven. Then you may also apply some say merry money, but my brother says big brains matter most. Okay, what would be the implication of your some say merry money, but my brother says big brains matter most? For example, if I'm talking about the facial nerve, I know that it would concern both sensory and motor functioning. Therefore, class, you would be triggered to think if what are the assessment findings, okay, in the sensory function of the facial nerve and then the motor function of your facial nerve. For example, since I'm talking about acoustic nerve as a purely sensory nerve, okay, we know that the assessment to check for the functioning of your acoustic would be geared towards the assessment of the sense of hearing of your patient. On the other hand, since we're talking about accessory muscle as a motor nerve, okay, which would mean this is mainly concerned with movement. So when we are assessing the function of your accessory nerve, we are not checking already on the sensation. Instead, we are dealing of the motor movement. Okay, probably the movement of your shoulder. Allow me to go quickly, one by one, among the 12 cranial nerves because this is crucial knowledge for you. Now, when I talk about cranial nerve number 1, that's your olfactory nerve. Of course, for the sense of smell. We commonly ask our patient to identify the smell of common objects. So you have coffee, vanilla, peanut butter, orange, lemon, chocolate. So an abnormality in your cranial nerve number 1 would entail, okay, anosmia. Anosmia is the inability of your patient to smell. That would entail damage, or that would mean damage on the frontal lobe of the brain or possibly your middle cerebral artery. Okay? Then you have your cranial nerve number 2. Your cranial nerve number 2 is your optic nerve. Okay, with the term optic, you would know that this is for our visual functioning. So assessment, you have your Snellen's test. Recall that your normal vision is 20/20. Okay, you also have your confrontation. When I say confrontation, you would ask the patient if they would say yes by the time they will be seeing your hands approaching the peripheral view. Then you also have your ophthalmoscopic examination. So your ophthalmoscope is the equipment that we use to visualize the inner structures of your eye. What are the possible abnormality related to your cranial nerve number 2 functioning? One is your unilateral blindness. Okay, take note of the term unilateral. When I say uni, meaning one side. Okay, one side on the lateral aspect would have blindness. So this is common among patients who had stroke and then among your patient who had TIA or transient ischemic attack. As I have mentioned, your TIA is your mild stroke. Okay, although it is mild, it is still considered an emergency initially until we can rule out a real stroke. So your unilateral blindness is a sign of your stroke. Specifically, we're talking here stroke on the occipital lobe. Because recall that your vision is interpreted on the occipital or posterior aspect of our brain. The next abnormality that can be developed is your homonymous hemianopsia. If you would look at the image on the left side of the screen, class, okay, this is your homonymous hemianopsia. When I say homonymous hemianopsia, both of the eyes would have this view. Okay, meaning both of your eyes has an impairment on the view on one aspect. That's why it's referred to as homonymous hemianopsia. Homonymous meaning the same between the two eyes, and then hemianopsia meaning one hemisphere of the eye is affected. This is also common among your patient who had stroke. Your double vision is also an abnormality of your optic nerve. Okay, so take note of this. Later on, when we will be learning about your cerebrovascular accident or stroke, these assessment findings will be crucial. Then we have your CN3, oculomotor. If you will apply our concept on some say Mary money, so your oculomotor is considered to be a motor nerve. Since it's motor, we will not be assessing for sensation here. Okay, so look at the function. EOM in my slides is your extraocular movement. So it is in charge also with the movement of your pupil sphincter, also the ciliary muscles of your lens. So class assessment, this can be assessed using your 6 ocular movement or your 6 cardinal directions of gaze. Recall in your health assessment that if I would want to assess the movement of the eyes, I would instruct my patient to follow my finger to move to this direction, go back to the center, move to this direction until you complete the 6 cardinal directions of gaze. Now, an abnormality on your oculomotor would entail the patient to manifest with nystagmus. So when I say nystagmus, there is repetitive, uncontrolled movement of your eyes. Okay? Again, repetitive and uncontrolled movement of your eyes. Furthermore, a patient with a damage on CN3 could also manifest with ptosis. Okay, so class, your ptosis is the drooping of your eyelids. The drooping of your eyelids is visible among your patient with stroke. Okay, among your patients with MG class in neuro, this is myasthenia gravis. Okay, we'll be talking about that in the future. And then also your palsies. Okay, they may manifest with ptosis. Okay, in our endocrine disorders, you might have encountered hyperthyroidism as one disorder that manifests with ptosis. So right now in neuro, we are talking about stroke, myasthenia gravis, and then your palsies. Now, your CN4. Your CN4 is your trochlear nerve. This talks about your extraocular movement still, and then concerned with the downward and lateral movement of the eyes. Since, if you will apply some say Mary money, this is a motor nerve, so we are still talking about movement. We are not assessing vision here. We are assessing movement of the eyes. So still, we will be still assessing the patient using the 6 cardinal directions of gaze. And then the abnormality of which is referred to as nystagmus. Class, on the presentation is a typical example of a patient with nystagmus. So that movement tends to be involuntary. Okay? Now, class, you might be wondering why this nerve is referred to as trochlear. Okay, your trochlea, class, could be found here. Your trochlea acts as a superior oblique. Okay? It acts as a pulley-like structure for your superior oblique muscle. So if you would look at this, this is your superior oblique muscle. So the one class that serves as a junction, okay, for the pulling of this muscle is your trochlea. Class, your trochlear nerve innervates the trochlea in your eyes. For that reason, class, it's called trochlear. Okay, so you have downward and lateral movement. If you understand the movement of your superior oblique, you will be able to deduce that it will be able to move your eyes downward and laterally. Okay, then CN5. Your CN5, some say Mary money but. Okay, but. So this is both. Okay, plus your CN5, also known as your trigeminal nerve. Okay, you need to remember this because we have a condition referred to as trigeminal nerve neuralgia. Okay, plus your trigeminal nerve, for us to understand it, is divided into 3 parts. Okay, or 3 branches. You have your ophthalmic branch, your maxillary branch, and then your mandibular branch. Look at the diagram on the right side of the screen. This will be able to explain to you the specific parts which are innervated by these specific branches of your trigeminal nerve. Okay, ophthalmic. If you would look at the ophthalmic branch class, it would be concerned of the sensory sensation of the cornea, skin of the face, and then the nasal mucosa. If I would look at the maxillary class, it is concerned with the sensation of the skin, face, and the anterior oral cavity. Your mandibular, on the other hand, is concerned about the motor and sensory function of this nerve. Class, your mandibular branch of the trigeminal nerve is the one that is in charge with mastication. When I say mastication, this talks about chewing. And it's also in charge with the sensation of this part of your face. So how do I assess? If I want to assess cranial nerve number 5 ophthalmic branch, ask the patient to blink. If I want to assess the maxillary branch, ask also the patient still to blink, and then you could also feel for the sensation on this part. And then class, for the mandibular branch, you can ask your patient to clench the teeth. Clenching the teeth will be able to help you to assess whether the mandible is able to move as it's supposed to. And then it's also able to assess if you can feel, class, the lower, if the sensation on the mandible is not impaired. Abnormality. There could be a decrease in sensation and there could be an experience of pain. Class, the pain experience usually is what we refer to as your trigeminal nerve neuralgia. Your trigeminal nerve neuralgia is your pain resulting from inflammation of your trigeminal nerve. Then you have your cranial nerve number 6. Your cranial nerve number 6 is also known as abducens. So class, your cranial nerve number 6 would still be on movement. So extraocular movement, the lateral eye movement to be specific. So assessment findings will be assessment of your 6 ocular movements. Abnormality of this cranial nerve would entail or manifest as nystagmus for the patient. Then you have your cranial nerve number 7. Class, your cranial nerve number 7 is also known as your facial nerve. Okay, class, your facial nerve would function for facial expression and then taste. For that reason, class, some say Mary money, but my brother. Okay, so both. The function of this one is both. Now, if you would look at it, to assess for the cranial nerve 7 functioning, you need to ask your patient to smile, to raise the eyebrows, frown, puff out cheeks, and then close eyes tightly, and then identify taste. Okay, class, if your patient is able to perform all of those, your patient's cranial nerve number 7 tend to be intact. Plus, the usual substance that are being used for taste discrimination is your sugar for sweet, then you have your salt, and then your lemon juice for the sour. Okay? Plus, abnormality of this cranial nerve would manifest as loss of taste, inability to close eyes, then a flattening of your nasolabial fold, and then paralysis of your lower face, and then even the reduction of the wrinkles or no wrinkling at your forehead could be a sign of CN7 problem. Okay, you have there the 5 branches on the picture on the right. So you have your temporal branch, you have your zygomatic branch, your buccal branch. You also have your mandibular branch, and then your cervical branch. Then class, you have your CN8. Your CN8 class is purely sensory. Okay, so that is your acoustic nerve. Class, your acoustic nerve is also known as your vestibulocochlear nerve. So you have vestibular and cochlear part of this nerve. Assessment. Okay, class, we are checking for equilibrium. As shown, class, on the slide, okay, on the left side, on the leftmost part of the slide is your Romberg's test, wherein you ask your patient to walk on a straight line for you to determine if they are able to walk correctly on a straight line. The ability to walk correctly on a straight line would signal that cranial nerve number 8 is okay and intact. Okay, then class, you have your whisper test on the middle, and then on the right, class, you have your Weber's test and your Rhine's test. Okay, remember, your Weber's test is the test for lateralization of the sound, whereas your Rhine's test is the comparison of your air conduction to bone conduction. So class, your Weber's test and your Rhine's test would be able to help us differentiate between conductive hearing loss and sensory neural hearing loss. Yes, there are 2 kinds of hearing losses. You have your sensory neural hearing loss and then your conductive hearing loss. We'll discuss that under ears. Then you have your CN9, glossopharyngeal nerve. Class, your glossopharyngeal nerve, okay, would allow us to swallow and the movement of the tongue and then also your taste, meaning its function is both sensory and motor. Assessment of this one is done through taste, movement of the tongue to the side. So usually tell the patient to move the tongue against the cheeks. And then at times you tell them to move the tongue against the cheeks and against the force of your palm. That's to evaluate for your glossopharyngeal nerve. Abnormality for the glossopharyngeal nerve would manifest as difficulty in swallowing, okay, or there could be a unilateral loss of gag reflex. That is common if the reason for the impairment of your glossopharyngeal nerve is the presence of lesions. Then you have your cranial nerve number 10, okay, your vagus nerve. Class, it's in charge of the sensation of the pharynx, larynx, the swallowing, and even the movement of your vocal cords. Assessment will be using taste and then the movement of the tongue from side to side. And then you also check for the hoarseness of voice because that will be an indication on the damage of the larynx. So class, abnormality of your cranial nerve number 10 would manifest as dysphagia. It could be also seen as unilateral loss of your gag reflex that would occur with lesions. So when I say lesions, class, instead of a bilateral effect, okay, it would be unilateral, meaning one side of the body is only affected. Now, on your cranial nerve number 11, your cranial nerve number 11 is also known as your accessory nerve. Class, your accessory nerve has the function, okay, of head movement and then shrugging of your shoulders. Meaning, class, it is your cranial nerve number 11 that would allow for the lateral rotation and then the internal and the external rotation of your neck. So how to assess? You would ask your patient to shrug the shoulders, and then you would ask the patient to turn the head to side and side. And then class, for the abnormality, okay, your patient will be unable to shrug the shoulder due to muscle weakness. Then you have your cranial nerve number 12. For your cranial nerve number 12, its main function is motor. So it is the one that would trigger the protrusion of your tongue and then move the tongue up and down and side to side. So for assessment, you would ask your patient to do the tongue out and then move it to side to side. Then you also ask the patient to touch the floor of the mouth and then class the upper palate or your soft palate for that matter. So to touch, I mean the soft palate and the hard palate. Abnormality of which can result to atrophy and fasciculations. So when I say fasciculations, these are involuntary movements. And then tongue deviation towards the involved side. Okay, that is cranial nerve number 12 deficiency. Now, during your physical assessment, you need to assess these cranial nerves from 1 to 12. That is part of your comprehensive neurologic assessment. Without doing so, you will be unable to determine the problems experienced by your patient in terms of cranial nerve functioning. Also, this will give you an idea on what part of the brain is damaged. Okay, if you would apply the concept of your blood flow going towards the specific area. Class, let's talk about your spinal nerves, or at least an overview of its anatomy. So class, your knowledge about the spinal nerves will be essential on our discussion for spinal cord injury. So remember, for your spinal cord injury, your patient may have the injury at the cervical spine, thoracic spine, and the lumbar spine. Okay, so class, damage on the cervical spine would result to disability from that part going to the lower part of your spinal cord. So understanding an anatomy and physiology will be important. Okay, now class, your spinal nerves. There are 31 of your spinal nerves, class. Okay, if you would look at the list, class, the vertebrae there are the bones that would refer to your bone that protects your spinal cord. Now, if you would notice the numbers, class, okay, there are actually a higher number of spinal nerves compared to your cervical bones. Okay, that would give us a hint that your cervical or your spinal nerve number 1, okay, is coming out above your cervical spine. Okay, try to find out the anatomy. How come that there are 7 vertebrae on the cervical, but there are 8 spinal nerves on that? Okay, so take note of this total. Now, class, there are 2 types of sensory fibers. The 2 types of your sensory fibers are referred to as somatic and visceral. So, class, when I talk about somatic, again, soma would refer to your body. So, the purpose of these sensory fibers would carry information about pain, temperature, touch, and possibly position. So class, when I talk about somatic, these are fibers that would arise from your tendons, joints, and body surfaces. Whereas your visceral sensory fibers are the one which comes from your internal organs. So meaning if you're complaining of stomach pain, it is your sensory visceral fibers on the work. Okay? If you are complaining that you're having pain on a certain part of your skin, that is your somatic sensory fibers on the work. So the cell bodies for your sensory fibers are located at the dorsal root ganglion. Okay, so meaning if we will have problems with the dorsal root of our spine, your patient would manifest with inability to feel that part of the body. Then class, we have your concept on autonomic nervous system. So class, here you can see that the autonomic nervous system would regulate the activities of our internal organs. That includes your heart, lungs, blood vessels, digestive organs, and glands. So this regulation of the activity is said to be involuntary. So when I talk about autonomic nervous system, this talks about involuntary control of your body organs. So its main goal is to maintain and restore internal homeostasis. So I hope that you're reminded in your lectures that your autonomic nervous system is of two divisions. So you have your parasympathetic and then your sympathetic nervous system. Okay, it should already be instinctive to level 3 students that when I talk about sympathetic nervous system, this talks about the excitatory response. Okay, think of your fight or flight response. Now, in your fight or flight response, it is your norepinephrine that is considered to be the main sympathetic neurotransmitter. So it is a sympathetic discharge that would release your epinephrine. So I'm talking about sympathetic class. Okay, the key word there is always to think that everything is up except for your GI. And that we're thinking always of your fight or flight response. And another way for you to remember is to think that sympathetic is dry. Okay, when I talk about sympathetic response, it results to dry responses. Okay, now going over, okay, I don't expect you to memorize all of this, but this should be familiar already to you, and you should be able already to explain how come these are all sympathetic stimulation. So whenever your sympathetic system is triggered, innervated class, okay, it would cause dilation of your pupils. Another term for dilation of the pupils would be mydriasis. Then there should be a decrease of secretions, meaning class there is a decrease of your urinary output. There is also a decrease of your GI output. Okay, there is decrease also of your secretions from the glands. Then there is copious production of sweat. Then you would expect that there is an increase in the heart rate and force of heartbeat. So class, the increase in heart rate is related to the demand of your body for increased oxygen. Now, the force of your heartbeat will be referring to the contractibility of your heart. Contractability of your heart. Contractions. Then, class, one thing that we remember about sympathetic nervous system is that it causes blood vessel constriction. Okay, we always think the blood vessels would constrict because it would be the one that would lead to increased blood pressure. But the specifics of your Brunner would tell us that it leads to vasodilation of your coronary arteries. Class, take note, the vasoconstriction that we have been continuously repeating in sympathetic nervous system is vasoconstriction in the peripheral aspect. So it is peripheral vasoconstriction. However, class, there will be vasodilation on the central circulation. Okay, sympathetic response is doing vasoconstriction because we would want the blood to be realigned on the major organs of the body. That's why we have the vasodilation of your coronary arteries. In other words, class, okay, your sympathetic nervous system would try to pull up the blood from your periphery and then allow that blood to supply your heart, your lungs, and then your brain. Later on, class, your kidney. Then it also results to the dilation of your bronchioles, meaning class, it allows for the entry of more oxygen. It facilitates the exchange of your gases. Then, as mentioned, there will be decreased digestion. Okay, class, the decrease of digestion is also related to the decrease of the blood flow to your GI tract. Okay, again, that's because of the prioritization of the major organs. So class, oftentimes we say dry because if there is decrease of digestion, class, there is decrease of peristalsis resulting to dry stools. Okay, dry stools. So how is that possible? The slow transit of your stools through your GI tract would allow for more absorption of water. With the more absorption of water, okay, your stool tends to be dry. Then we have the increased release of glucose by the liver. So class, this is your glycogenolysis, okay, and your gluconeogenesis. Those are the two roles of your liver. Okay, glycogenolysis will be the breakdown of your glycogen going towards glucose, and then your gluconeogenesis is the utilization of amino acids to form glucose. So you might be wondering, why is the purpose of increase of glucose? Take note, flight or fight response. If you would want to go on a fight or flight, you need a lot of glucose. Then decrease urine output. In an attempt to conserve the water of the body, class, okay, the urine output is being decreased. So meaning there is an increase in the production of your antidiuretic hormone and also your aldosterone. Now, there will also be vasoconstriction of the arteries, and the attempt for that or the goal for that is to increase the blood pressure. Furthermore, there is vasoconstriction of your abdominal and skin blood vessels. There is increased blood clotting. There is increase in the metabolic rate, and mental alertness tends to be increased. Okay? Because class, your flight or fight response would allow you to focus on what you need to focus on. That's why if you tend to become anxious, class, there is an increase of your metabolic rate. Okay? Your increase of mental alertness may be congruent only to mild anxiety. But beyond that, okay, your patient will not be manifesting with mental alertness. But the goal of your SIMPA nervous system is to increase your mental alertness. Then, we have your parasympathetic nervous system. So, class, basically, your parasympa would be the opposite of your sympathetic responses. Come to look at it, there will be constriction of your pupils. Plus, the constriction of the pupils will allow for the release of your aqueous humor. Okay, again, we always think of your pupils as a passageway. So, class, that's why we would associate constriction of the pupils with a quote-unquote wet response. So, this wet response, class, is because of the flow of your aqueous humor. Furthermore, if we're talking about endocrine system, it leads, class, to the stimulation of your glandular secretions. Meaning, class, the glands of our body would increase its secretions. If I'm talking about your stomach, there will be an increase of your acid production. If I'm talking about your pancreas, there will be an increase of your amylase and lipase. So look at this. There's decrease of heart rate. Okay, earlier we had vasoconstriction of peripheral vessels, then vasodilation of coronary arteries. So in your parasympa, it would be opposite. Okay, the coronary arteries are constricted. Then there will be constriction also of the bronchioles. Your patient may have loose stools due to increased peristalsis, okay, leading towards diarrhea-like symptoms. Furthermore, okay, you also need to know about the two neurons of the corticospinal tract. So, class, you have your upper motor neurons and then your lower motor neurons. Okay, wise for you to know that the upper motor neurons, class, when I talk about upper and lower motor neurons, just think of this as the location of the neurons. So when I say upper motor neurons, they usually originate from the brain going towards the spinal cord. When I say lower motor neurons, these are the neurons from the spinal cord going towards the peripheral organs. So if you would look at the definition, your upper motor neurons would originate from your cerebral cortex, from your cerebellum, and then your brainstem. Okay, these are the fibers that would make up the descending motor pathway, and later on, class, they would modulate the activity of your lower motor neurons. Now, the damage on your upper motor neurons, such as in stroke and spinal cord injury, can possibly result to paralysis. Thus, your paralysis may manifest as hemiplegia. It may also manifest as paraplegia. It can also manifest as tetraplegia. Class, when I talk about paraplegia, okay, we are talking about possible damage on T1 to T12. Okay, we are talking about possible damage on T1 and up to T12. When I talk about your tetraplegia, class, usually the damage will be from C1 to C8. Okay, if you would look at it on that definition, which do you think appears to be more severe? Is it your paraplegia or your tetraplegia? Okay, again, paraplegia would damage possibly T1 to T12, whereas tetraplegia would damage C1 to C8. Okay, so which do you think would have more damage? So, class, the more damage will be on your C1 to C8. Okay, come to think of it, it is your cervical vertebrae that comes first, followed by your thoracic, followed by your lumbar. Class, whenever you have a problem with the cervical vertebrae, meaning, class, it is not able already to transmit the signal going towards the thoracic, going towards the lumbar. Okay, if you would look into the definition of paraplegia and tetraplegia, class, paraplegia would involve paralysis of the lower extremities. Whereas when I say tetra, okay, tetra would mean 4. Okay, class, this is already the paralysis of your 4 extremities. Okay, you get a leg which is not moving, both legs not moving, class, and then your arms are not moving also. That's what we refer to as tetraplegia. Now, if you are wondering if what is hemiplegia, class, hemi is half, meaning there is a paralysis of half of the body. Now, when I talk about your UMN damage or your upper motor neuron damage, this also manifests with hyperactive deep tendon reflexes. Okay, hyperactive deep tendon reflexes. Now, let's go to your lower motor neurons for us to differentiate. Class A, by the way, this is an illustration of your quadriplegia. Okay, also known as your tetraplegia, then you have your paraplegia, and then you have your hemiplegia. I mentioned that quadriplegia is usually associated with damage on the cervical vertebrae, okay, or your cervical part of your spinal cord. Your paraplegia is usually associated with the damage on your thoracic and then your lumbar part of your spinal cord. Whereas class, your hemiplegia is usually brought about by the damage on the brain itself. Okay, class, if you are looking at the patient, for example, on this one with damage on the left side of his body, okay, I think that's the left side of your patient. Class, we can deduce from here that it is the right side of the brain which is affected. That is brought about by the decussation of your cranial nerves, or specifically the decussation of your spinal cord going towards the periphery. When I say class decussation is the crisscrossing of your nerves. So meaning the nerves that emerge from the right side of the brain is going towards the left side of the body. So the term for that anatomically is decussation. Now, to differentiate again for the two, so class, this is a table derived from a book in medicine, okay, to differentiate your upper motor neuron and lower motor neuron problem. So in an upper motor neuron problem, we have what we call your atrophy of disuse, meaning you are not using that part of the body, it results to the decrease in its size. Whereas class, in a lower motor neuron, there is what you call atrophy of denervation. So when I say class atrophy of denervation, okay, remember we have been using the term innervation. When I say innervation, meaning your neurosystem is capable of stimulating that part of your body. When I say denervation, there is no nerves, or the nerves are incapable of firing signals going toward that part of the body, meaning it is unable to move, leading again to atrophy. Plus, your fasciculations and fibrillations are more common in a patient with lower motor neuron. On the other hand, class, for tone, okay, this is very important for us to remember. When a patient manifests with spasticity, meaning class, there is a rigidity of the extremities, that is usually an upper motor neuron damage. Whereas, if your patient would appear to be flaccid, okay, there is flaccidity, meaning class, the patient is just weak, unable to move the extremities, that is usually associated with lower motor neuron damage. Okay, class, look at the distribution. For an upper motor neuron damage, as what we've touched earlier, okay, there is a possibility for hemiplegia, okay, paraplegia, and quadriplegia. Class, this possibility is brought about by the pyramidal or regional damage in your upper motor neuron. So class, when I say pyramidal or regional damage, meaning a set of nerves are being ruined, okay, are being affected or destroyed. Okay, sorry for the term ruined. But then class, for the lower motor neurons, it is distal or segmental, meaning only a few part of the nerves is damaged. So it is possible that it's only the hand of the patient which is affected. Okay, for example, the right hand or the right arm of the patient for that matter. Then tendon reflexes. Class, tendon reflexes or deep tendon reflexes is expected to be hyperactive in upper motor neuron. So you're expecting here 3 plus or 4 plus or maybe 5 plus for your deep tendon reflexes. Okay? Then class, for your clonus and Babinski, it's expected to be present in your upper motor neuron problem. Now, I hope that you still know how to test for your Babinski reflex. But class, okay, please do not conclude that if a 6-month-old would have Babinski reflex, that would mean that the patient has an upper motor neuron damage. Please take note that your Babinski reflex may still be considered normal up to 1 or even up to 2 years of age. Okay, so beyond that, it's considered to be abnormal. It may signal an upper motor neuron damage. Okay, upper motor neuron damage. In the succeeding topic, we'll be discussing about assessment. So that's the application of your physical assessment and then your interview when it comes to dealing with a patient with neurologic problems. Thank you for your attention on this one.